live. So we are live. Welcome everyone for a new appointment of what we like to call the Coffee Talk organized by ISCAS, the International Society for Coronary Artery Surgery. These are Saturday morning or Sunday morning appointments
International Society for Coronary Artery
that
Surgery.
We organize in order to implement, to learn, to educate the coronary surgeons and the cardiologists around the world. ISCAS is the society that sees as a president Dr. John Pascas, who is joining us today, director of the Coronary Surgical Revascularization Program at Mount Sinai in New York City, and the vice president, Dr. David Taggart from University of Oxford. These events have been an appointment that allow us really to understand, to connect with a lot of surgeons around the world. And we want your impression or your feedback. You can interact with us by asking questions in every comments section of each platform that you are using to see this live stream. So please interact with us, ask us questions during the presentation. Today, we will speak about FAME-free trial and the results that has been published on New England Journal of Medicine. And we have with us two incredible guests. Dr. William Fearon is the professor of medicine, cardiology, and director of the interventional cardiologist at Stanford University School of Medicine. It's 8 o'clock in the morning in the West Coast, weekend of Memorial Weekend in the United States. So thank you so much, Dr. Fearon, to make that happen and to be here with us. And we have also Dr. Philip Kasselman, that is a staff surgeon at Ons Lieve Vrouw Ziekenhuis in Aalst, Belgium, one of the authors of FAME-free trial in the publication. Is very committed to participate to this talk, is in fact in transit after being in a board meeting for the European Association, and he will be one of the surgeons of FAME-free trial. I do not want to take any more time. I introduce myself saying that I'm a young surgeon. I work in Philadelphia at Mainline Health. I'm a very dedicated coronary surgeon. I love coronary surgery. I learned from Dr. John Pascas, that is one of my mentors, and I'm here to learn from all of you. I will give the floor to Dr. Fearon, and I will ask him to start to present some of the data that we have all read on New England Journal of Medicine about the FAME-free trial. Please, Dr. Fearon.
Thank you, and thank you all for the invitation to be here. It's an honor and a privilege to be part of this, and I look forward to the discussion. What I thought I would do is just briefly give an overview of the FAME-3 trial and the main results, and then discuss 4 lessons that we've learned. These are my disclosures. So the FAME-3 study was an investigator-initiated, multi-center randomized controlled trial. It included all comers with 3-vessel coronary disease not involving the left main that each site's heart team felt were amenable to either PCI or CABG. 48 centers in Europe, North America, Australia, and Asia participated. And patients were randomized in a 1-to-1 fashion to either FFR, fractional flow reserve, guided percutaneous coronary intervention, where all lesions with a low FFR were stented, or to coronary artery bypass graft surgery. The primary endpoint was the 1-year incidence of all-cause death, MI, stroke, or repeat revascularization. This was a non-inferiority trial, and the margin was set at a hazard ratio of 1.65. The baseline characteristics are shown in this slide. You see that the average age was around 65. Most of the patients were white men with typical risk factors. About 30% were diabetic, and about 40% presented with an acute coronary syndrome. As far as procedural characteristics, Not surprisingly, the time to the procedure duration, and the length of hospital stay were all shorter in the PCI arm compared with the bypass group. A similar number of lesions were identified, just over 4 lesions per patient. About 20% of patients had a chronic total occlusion, and about 2/3 had at least one bifurcation lesion. The average syntax score was 26 in both groups. Some more details regarding the procedure. In the PCI group, FFR was able to be measured in 82% of lesions, and 24% of those had a negative FFR. About on average, 3.7 stents were placed per patient. Intravascular ultrasound, or OCT, were utilized in 12% of patients, and fractional flow reserve was measured after PCI in 60%. In the bypass group, FFR was measured prior to bypass in 10%. On average, patients received 3.4 distal anastomoses. A quarter of patients received multiple arterial grafts. The vast majority received internal mammary artery graft, and off-pump surgery was performed in about a quarter. So the primary endpoint was, again, the rate of death, MI, stroke, or repeat revascularization. And as you see from this slide, it was 6.9, or occurred 6.9% of patients in the bypass group and 10.6 in the PCI group. It did not meet the preset hazard ratio for non-inferiority. The upper bound of the 95% confidence interval was 2.2, which was above 1.65. So PCI was not non-inferior to bypass. When we look at some of the key secondary endpoints, there were no significant differences between them, although some numerical differences. The rate of death, MI, and stroke occurred in 7.3% of PCI and 5.2% of the CABG group. Safety endpoints, severe bleeding, acute kidney injury, and significant arrhythmia occurred less frequently in PCI patients compared to bypass. Fortunately, stent thrombosis and graft occlusion were fairly rare occurrences, and rehospitalization within 30 days occurred less frequently after PCI compared to bypass. So I'd like to just go through 4 lessons that I think we can take home from FAME-3. One of them is that compared with historical data, the outcomes with both FFR-guided PCI with current generation DES and CABG have improved significantly. If you compare the characteristics of the patients in FAME-3 to those that were enrolled in the syntax trial, you see that they were fairly similar, with a similar percentage of men and age and risk factors, and even the syntax score and the number of lesions were reasonably similar. However, when you look at the outcome, which had a similar composite in both studies at 1 year, both the PCI arm and the CABG arm in FAME-3 are numerically better than the CABG arm in the syntax study. In fact, we had designed FAME-3 based on an expected rate of what was seen in syntax CABG group, and it looks like we might have met non-inferiority if that had happened. But as you can see, the CABG group did quite well in FAME-3, but the PCI arm also did quite well against historical control. A second lesson is that for any test, in this particular example, we're talking about FFR, to have a positive impact on outcomes, it needs to be used in a population and or in a manner where it'll actually impact decision-making. And so there's another study in the interventional cardiology world that has recently been published that was called FUTURE. This is a study of almost 1,000 patients with multivessel coronary disease who had their treatment based either on angiography alone or fractional flow reserve guided angiography, I should say. And what you see in this study was that in the FFR group, only about 8% more of patients were switched from medical therapy, from PCI to medical therapy. So there were slightly more patients getting medical therapy and slightly less getting PCI. The group sent to CABG was similar. So really, there was very little difference in the treatment strategies between the two arms. FFR had little impact in this study for a number of reasons that are beyond the scope of the discussion. But if you can go to the next slide, you see that the primary endpoint is no different. And it's not surprising when this you use a test and it has little impact on decision making, you're not going to get any difference in events. Now let's go to the next slide. Another study that's received a lot of attention was the Flower MI trial. This is a little over 1,100 patients with STEMI who were found to have multivessel disease at the time of their STEMI, and their non-culprit vessels were randomized to either FFR-guided or angio-guided assessment and treatment. And what you see is that, if you can go back one, the outcome was identical between groups. And again, it's not too surprising when you consider that both groups had a STEMI and underwent primary PCI. Likely that's going to dictate most of the events. 2/3 of the FFR-guided patients underwent non-culprit PCI, just like in the angio group. So again, they're going to have similar outcomes. So only about 200 patients in the FFR-guided arm had a different treatment than in the angio-guided group, and you might expect a different outcome. And so when you think of it this way, you realize again that if you do a test and it's not going to impact your decision making, it's probably not going to affect events. And so now if we can go to the next slide, in FAME3, I think this is relevant when you look at the high versus low syntax score groups. You see in the low syntax score groups, the PCI arm did just as well, if not slightly better than the cabbage group, whereas in the high syntax score group, the opposite occurred. And when you look at the percentage of lesions where FFR was negative, it was much greater in the low syntax group. And what this means is that, FFR, the main benefit is from deferring unnecessary PCI. And so in less complex disease, it's really where you reap the benefit of an FFR-guided approach, and where PCI may have a role compared to the more complex patients where it really doesn't matter whether you measure FFR or not, because they're all positive and they're all complex disease. So the third lesson that I wanted to mention was that not all quote unquote hard endpoints are really that hard. And in particular, this is what I'm speaking about is myocardial infarction and procedural MI. And this, as you all know, has been a very controversial topic lately. In the FAME3 trial, we defined procedural MI in the same way for both the bypass group and the PCI group, believing that this would help reduce ascertainment bias by the clinical events committee, and so they could remain blinded. And also because I'm not sure we really should have a different definition for the two treatments. In FAME3, we used a fairly strict definition that was similar to the universal definition for procedural MI for the cabbage group. You had to have elevated biomarkers and at least one of the following, either new Q waves or an angiographic evidence of coronary occlusion or imaging evidence of new loss of myocardium. Now, there's another definition that some of you are probably familiar with from the Society of Cardiac Angiography and Interventions, which uses two different definitions or components. One is a biomarker only, where all you have to have is elevated biomarkers. And then the other is biomarker plus new Q waves. And the reason I mention this is because when you look at the rates of these different definitions, it could impact your interpretation of the study. So again, this is the FAME3 definition that we used, which had a fairly strict definition, and therefore the procedural MI rate was quite low in both groups and not really different. Now, when we look, I'm not sure why it didn't show up. I guess because the animation didn't get transmitted when I sent it to you by email. But in any case, what's supposed to show up on the right-hand side is then the SCAI definition. And the first thing to note is that the rate of procedural MI was much higher in both groups. It occurred in 10% in the PCI arm and 14% in the bypass arm. And so obviously, that could totally change your interpretation of the study. And it just highlights how procedural MI, in my opinion, is really a kind of more of a soft endpoint than a hard endpoint. So the next slide highlights the last lesson that I would like to mention, and this is that although PCI did not achieve non-inferiority, the event rate between PCI and CABG was relatively small, 3.7% absolute difference, with no difference in stroke and death. And because of this, this for patients and for physicians, other aspects or other differences between the strategies become more important, like quality of life and certainly angina relief. And so if we go to the next slide, you'll see the quality of life data from FAME3 that were presented a month or so ago at the ACC by my colleague, Dr. Frederick Zimmerman. And what we looked at was the EQ5D summary score at 1 year, and it was not different between the two groups. However, on the next slide, you'll see that the trajectory of improvement, not surprisingly, was significantly better for PCI, given the earlier recovery that is associated with that strategy compared with bypass. The other thing that we looked at was angina relief. And around 75% of patients had significant angina, class 2 or greater. However, I don't know if the animation is going to show up. Oh, good, it did. You'll see that there was impressive angina relief in both groups throughout the study. And by 1 year, there was really no significant difference in significant angina between the PCI and bypass groups. And then finally, we looked at working status in those patients who typically are working, those less than 65 years old. And again, not surprisingly, early after surgery or PCI, there were significantly more patients after PCI who had returned to work, and that persisted. So even at 1 year, there was a greater percentage of patients returned to work after PCI. So in summary, I think FAME3 has taught us numerous lessons. FFR-guided PCI did not meet the criterion for non-inferiority to CABG. That's probably the most important one. Outcomes with both FFR-guided PCI and bypass are significantly improved when compared with historical data. In less complex disease, where measuring FFR can actually have an impact, FFR-guided PCI performed very favorably in comparison with bypass. Endpoint definition, particularly procedural MI, clearly affects one's interpretation of FAME3. And quality of life at 1 year is similar after FFR-guided PCI compared with bypass. And overall quality of life during the first year is better after PCI, and significant angina is infrequent and similar in both arms at 1 year. Thank you for your attention.
Thank you so much. Thank you for this presentation. It was an excellent presentation and a great review of FAME3 trial. I'm sorry for that slides that didn't catch up. I want to immediately give Dr. John Pascas the point, and Dr. David Taggart. I want to have, after this presentation, some feedback from the two of you. What do you guys have thought about FAME3 when you have seen it? Where do you think are the strong effect? Why CABG did so well in almost unexpectedly, I would say, so well already at 1 year? Dr. Pascas, we'll start with you.
Good morning. I want to also hear from Dr. Kesselman about the FAME trial, but let me kind of tee it up for him, if you will, by asking Dr. Fearon first, thanking him for a terrific presentation and for his leadership in this very important trial. And I should also say a very well-written and I thought very balanced, even-handed kind of report of the data in the New England Journal. There were some things about this trial that startled me. The first was a 1 year endpoint for a comparison of CABG versus PCI, which I would consider a very early interim analysis. And I frankly don't think any trials of CABG versus PCI should ever be powered on a primary endpoint at 1 year. Unless, of course, we're going to enroll only patients who have a 2-year life expectancy. And then the results of that trial may be generalizable to that population alone. So I guess the first question for Dr. Fearon is, what will be the longer term follow-up? Is funding guaranteed by the corporate sponsor? How will this play out? Will we see a cat and mouse of not wanting to follow up the data because it's not favorable to PCI over longer follow-up, or will we see genuine acquisition of data and the very even-handed, transparent publication of the data that you've provided in your one-year manuscript? The second question I have is really a comment. The syntax score of the patients enrolled in this trial was 26. That is relatively low complexity or low intermediate complexity coronary disease. Of those patients, only 29% had diabetes. The patients for whom we provide coronary surgery almost always have syntax scores in excess of 26. And at least in New York City, about almost 2/3 now have diabetes. I mean, diabetes is the norm, not the exception, in our surgical patient population. So then I worry about generalizing from a trial that enrolls patients that are frankly more favorable to PCI than to CABG, with a shorter follow-up, which will also favor PCI. And yet, strangely, PCI did not beat CABG, in fact, lost to CABG at 1 year. And that surprised me. I don't have a good explanation for that. I don't know why PCI had so few adverse events and CABG even fewer adverse events. I'm sure that you, Bill, and the others who designed this trial and powered it, predicting event rates and developing your enrollment numbers based on those calculations, you're very surprised and wondering, scratching your head as well. It's not because they did a lot of arterial grafting. Just 25% of patients had more than one arterial graft. And while that's better than the national norm in America, it's certainly no glorious benchmark that we should aim for. In our own practice, virtually every patient has more than one arterial graft, and 2/3 or more have only arterial grafts. So we would anticipate that some of those vein grafts will undergo attrition over time. And I'd be very curious to see what outcomes are for this trial at 5 years and then 10 years or beyond, because I think we'll learn some things from that. Let me stop there and ask Dr. Fearon to respond. I also would like to hear the surgeon's perspective from Dr. Kesselman, who I know is on a train in Paris at the moment.
Sure. Thank you for those comments. I'll start off with the 1 year endpoint. And I fully agree that particularly in this type of trial, longer term outcomes are critical. And yes, we have funding. The way FAME3 was set up is that Stanford University is the sponsor, and we received institutional research grants from Medtronic and from Abbott to run the study. And we are entirely in charge of coordinating it and running it, and we've made sure that we've saved enough money. Although, as you guys know, that can be quite challenging in these types of studies. And we will do 3 and 5 year follow-up. That's ongoing. In fact, we hope to complete 3 year follow-up at the end of this year and perhaps present those data around this time next year. Why we chose 1 year is another good question. And there's a lot that went into it. One was we wanted to compare with a historical trial syntax. And so we wanted to have the same endpoints and the same time frame and minimize the variables and just compare adding fractional flow reserve and adding newer stents. How does that impact outcomes? And so that was sort of the main reason. I mean, there's other reasons too. The longer you have follow-up, the more treatment strategies change and the less relevant a treatment becomes. Bioabsorbable scaffolds were coming along around the same time. We were concerned that our trial may be completely irrelevant. We feel like we dodged a bullet in a sense there, right in the middle of the study. They became commercially available in the US, and we were concerned that if they were shown to be better, people would just say, oh, who cares about FAME3? It was using an inferior stent. So all of these things go into, designing and the time frame of the endpoint. As far as I agree too that the current patient population getting bypass surgery is probably more complex than those that were included in the study. But I think, that argues that we are doing PCI perhaps in patients that shouldn't be getting it, given that FAME-3 showed, that it was not non-inferior in these less complex patients. So I mean, I think that's a win if you're, thinking of it that way for the surgeons, because probably there are patients that shouldn't be getting PCI that are. If in New York, 2/3 are diabetic and they all have higher syntax scores. Why the endpoints were so much better? I mean, I think a lot of things have changed on the PCI arm. I think certainly the stents have improved, as well as our radial approach, our approach to antiplatelets and bleeding. The death rate, for example, in syntax was 4% at 1 year, and in FAME-3 it was only 1%. And I think that has a lot to do with procedural complications being lower, and better stent technology, lower repeat revascularization. Again, I commented on our definition for procedural MI. That certainly had an impact. When you look at syntax and other studies, the rates of procedural MI were higher. And in the bypass arm in particular, it was interesting. I don't know for sure, and I'm interested in your guys' comments on why bypass did so much better. I mean, there isn't, in my opinion, something you can hang your hat on that has revolutionized bypass. Although I would say, anecdotally, or from my vantage point, it seems like at least our surgeons are becoming more, or have, I won't want to say meticulous, or just more cognizant of avoiding procedural complications and stroke and things like that. And I think that's probably improved it. But the thing that was most remarkable was medical therapy. At least if you compare to syntax, in FAME-3 at 1 year, about 95% of patients were on statins, whereas in syntax it was like maybe 70 or 75%. There are a higher number of patients on beta blockers, and I think our medical therapy has improved, and I think that may have an impact too. I fully agree. I don't think it's arterial revascularization, because first of all, it wasn't any higher, multiple arterial, and I would expect if there is any difference with that, it would take a lot longer to bear out.
As always, Dr. Fearon, very insightful and even-handed comments. You're a genuine collaborator in this field, and I think that we all as surgeons respect your opinion greatly. Let me ask you one question about the syntax score. You commented that with syntax scores being so low in this trial and CABG still outperforming PCI, perhaps more patients should be having coronary bypass, or fewer high syntax score patients should be having PCI. And yet the recent guidelines approved by SCAI and ACC-AHA have made the calculation of a syntax score much more optional, a 2B recommendation, rather than something that is more strongly recommended, as has been previously in all the predicate guidelines. Is this opening the door for ad hoc PCI without any accountability on a quantitative basis? What are your thoughts on the impact on practice of downgrading the recommendation for calculation of the syntax score in heart team conversations, as ascribed by SCAI and others very recently?
Yeah, it's a great question. I wasn't involved in that downgrading, so I can't speak to what led to that. I would say my personal experience and the way our heart team works is that we certainly look at factors that are, part of the syntax score, but I can't say we hang our hat on the syntax score, because we found, and I know others have shown this, that there's a large variability in the calculation. In fact, we saw this, and we'll publish some of these data ultimately in FAME-3, the relationship between site-reported syntax score and our core lab. And so for that reason, I'm not sure the syntax score is the best metric. In addition, as we all know, a lot of clinical variables, which aren't part of the syntax score, play a very important role in determining patient outcome between the two strategies. So I think there is a need to have objective measures to help guide us. I'm just not sure if the syntax score is the right one. Maybe syntax score 2 or one of these more nuanced scores that include clinical variables as well as just angiographic ones. I think for PCI, the syntax score does discriminate quite well, but as we all know in CABG, it doesn't really determine outcomes very well.
That's absolutely true. I'd love to hear from Dr. Castleman as our surgeon author, and then of course from Dr. Taggart, who I think has a more encyclopedic knowledge of the comparison of CABG versus PCI than anyone I know. But Dr. Castleman, can you give us your surgeon's perspective before your train pulls out of Gare du Nord?
Yep. Okay, thank you. Well, first of all, thank you for the honor of being present here. And then also congratulations, Dr. Fury, for performing really a great job with this trial. Now, many of the comments that I had in mind have already elegantly been exposed by you, John. But let's say that when I saw the results of the FAME trial, I'll give 2 short comments for the time being. First of all, I was, as you, really disappointed in the low rate of multiple arterial revascularization. It's barely higher than in the syntax trial, and yet, I mean, we have 10-year results from the syntax trial. So I think as surgeons, we still have a lot of work there to do, because I personally think, especially when you look at the mean age of the trial is 66, we have quite some work to do to improve our results. And we are already better, but I think we can still improve. That's one thing. And then the other comment that I would like to make is the point of the quality of life is well taken. Surgery is more aggressive, obviously, than a percutaneous approach. But my comment to that would be the mean age of these patients is 66. So normally these patients still have quite a good long life expectancy. And obviously you have to start a trial and you do short-term follow-up, and we hope to have longer-term follow-up. But the chances that these patients will benefit on the longer term are quite important. And we have a 3.7 or 3.9 difference now between percutaneous outcome versus of surgery versus percutaneous. But we are very eager to see the later results, because in most trials the curves keep on diverging. So when you have patients that are younger, they most likely will benefit more on the longer term. And the quality of life issue for me at the moment would be rather restricted to more elderly patients. So I think that patient profile is probably more important as a factor to decide which therapy one patient should get, rather than the quality of life. I would relate that to the patient profile. Okay, for now, these are my 2 comments. I'll keep listening to you guys, but I have to catch a train and I'll come back.
Sounds
I agree with everything Philippe said, and I think it dovetails into what Dr. Ferron said. You know, every remark that you've made, Bill, has been right on. You know, I do think that we surgeons have, you know, we have to look in the mirror and say, why in the world are we doing exactly the same operation that was done in syntax a decade before? Maybe with more attention to detail, maybe more meticulously, and certainly with remarkably good short-term results. But if we're going to say that coronary bypass should be offered to young patients and not PCI, then we better be offering 2 or 3 arterial grafts and not almost always one. I think that's just a fact. And as Dr. Castleman said, we surgeons need to look in the mirror and up our game, because quite frankly, and to their credit, our interventional colleagues have upped their game. PCI is remarkably safe. And I commonly send patients who are referred to me for very high-risk coronary bypass, I commonly will send them to my interventional colleagues. I am a significant referrer to the cath lab. Not every patient should have a sternotomy. That is just not a fact. Some patients should have culprit lesion PCI and go home to their couch. And in general, I think that we as a surgical and medical collegial profession, I think we do too much PCI in young patients and too much CABG in old patients. I think that this concept of assessing not just the syntax score, but the comorbidities and goals of the patient at this stage of life makes a big, that really is where the rubber hits the road. That's where the multidisciplinary team needs to provide the best care for the individual patient. But let's hear from Dr. Taggart, who, as I said, I think has a more encyclopedic knowledge of the history of comparing cabbage and PCI than anybody I know. Professor Taggart.
Thank you, John. And first, congratulations to Dr. Fearon and the FAME3 investigators for a number of reasons. I think they've done a trial that is extremely pathophysiologically important. I'll come back to that. And secondly, I think, as John alluded to, they reported their findings with remarkable honesty. There was no attempt to distort or manipulate the data that they had in their paper. And that's not always been the same for all reporting of PCI versus cabbage. So I congratulate them on that. To me, I think what they've done that's very important is they've addressed the outstanding pathophysiological issue of the difference between stents and cabbage. So they have shown us what many surgeons have believed for decades, that the difference between cabbage and PCI is that they achieve different pathophysiological objectives. And every time cabbage is shown to be better than PCI, it's always met with the refrain, oh, we used an old generation stent or we didn't use FFR. So what FAME3 has shown us is that using the best generation drug-eluting stent and doing it with FFR, cabbage still appears better, even at 1 year. And I have two comments to make about that. The first is that I suspect that what you'll find when you look at the 5-year results is that those margins between cabbage and PCI continue to widen. We've seen it in every large propensity match registry. We've seen it in patients with and without diabetes. We've seen it in Noble, Syntax, XL. So my very strong prediction will be that at 5 years, the gap you've seen at 1 year will be substantially wider. So I then would just like to conclude by making two brief comments. So why did cabbage appear to be better even at 1 year, so long before we get to 5 years? And I think Dr. Fearon answered it. Our own group published a paper in JACC 2 or 3 years ago showing that in patients undergoing cabbage, even in trials, there was systematically inferior use of guideline-directed medical therapy. And we showed that the failure to use optimal medical therapy in the cabbage patients led to increased mortality and MACE, even before 5 years. So I think what Dr. Fearon has said is probably the difference at 1 year is the great attention to detail in this trial to make sure cabbage patients were getting treated better than in previous trials. But saying that, I still expect a wide difference at 5 years. The second point I would make is that while I congratulate the investigators for their trial and the honesty with which they've reported the results, I would personally say it's unethical to do a trial of PCI versus cabbage with a 1 year primary outcome, because all the data in the literature for the last 2 decades has shown us that is wrong. So my argument would have been certainly do the trial, but call the 1 year analysis an interim analysis, but where the primary outcome should be at 5 years, because without that, I don't think is either scientifically or clinically really meaningful. So that would be my strong recommendation. I would also take a slight issue with the statistical having very wide upper margin boundary of 1.65, but we can discuss that again. So in my overall view of this, again, I would like to congratulate the investigators. I think in due course, it will become to be one of the most, if not the most important trial ever done of PCI and cabbage. It addresses the constant limitations that were expressed about the Syntax trial, not using the best stent, not using FFR. And again, as I've already alluded to, I would congratulate the investigators for what I felt was remarkably honest reporting of their findings. There was no attempt to manipulate or disguise or distort that. So thank you.
Well, thank you for those comments. And also thank you, Dr. Castleman. I just wanted to go back to Dr. Castleman's comments and first thank him and his site, which was one of the highest enrollers, the Cardiovascular Center in Aalst, Belgium, in the FAME-3 trial. And his interventional colleague, Bernard de Bruyne, has been a terrific mentor and collaborator for me over the years. And so I appreciate that relationship. And I fully agree with Dr. Castleman's comments about quality of life and the probably less importance in younger patients compared to older ones. And I think a lot of these comments are kind of highlighting what may be the most important take-home message, which I didn't really mention in my presentation, but just that we now have more contemporary data in order to make shared decisions with our patients and allow everyone to be better informed and about outcomes. And of course, you can't make blanket statements. Every patient's different, and some patients may do better with one approach versus the other. As far as Dr. Taggart's comments, thank you for those. I fully agree that the event rate will continue to widen, particularly when we talk about repeat revascularization. I think it'll be interesting to see. I agree that likely myocardial infarction will continue to widen too, given the difference between PCI and CABG, where we're fixing the focal lesion, you bypass the entire vessel, and therefore prevent future culprit lesions from causing MIs down the road. But we do know that these newer stents do have less late complications, and so it'll be interesting to see if it widens as much as, for example, in the Syntax trial or not. Particularly when you focus just on death, MI, and stroke, and remove repeat revascularization from the curve. The wide margin of the non-inferiority margin is I think, an interesting thing to talk about. And, we carefully thought about that. I think one of the rationales for having a fairly wide one was because repeat revascularization was part of the endpoint. And both for patients and physicians, I think the impact of repeat revascularization has lessened. In most cases, it's an outpatient procedure. It's like almost going to get your teeth cleaned, and so should that be weighted the same way as having a stroke? I'm not sure. And I think because we included that in the composite, we felt justified. And also there was other literature that we felt justified allowing us to have a wider margin than you might think is appropriate. The last comment I'll make, I hope people think that FAME-3 was contemporary PCI and they won't throw stones, but already there have been some thrown, if you go onto Twitter, from my colleagues regarding the lack of but the low rate of use of intravascular imaging, IVUS or OCT, because studies have shown that IVUS-guided PCI improves outcomes. And so people say, oh, well, PCI wasn't done as well as it should have been. And that may be true. We're going to look at, there was about 10 to 15% of patients who had intravascular imaging guidance. We'll look at their outcomes versus those that didn't and see what it shows. I would mention that there was a study called the Syntax 2 trial, which was kind of an observational registry that looked at contemporary PCI with current generation DES, physiology, and intravascular imaging. In fact, 85% of the patients in that group of PCI had intravascular imaging, and it wasn't randomized. They just all got PCI, and then they were compared to the historical Syntax trial group, and they did better, not surprisingly. But interestingly, when you look at the MACE rate, which was again a similar one-year composite in the Syntax 2 PCI group, it was identical to the FAME-3 group in PCI, even though 85% got intravascular imaging, and the repeat revascularization rate was very similar. So again, this is kind of comparing apples to oranges because, it's different studies, but it does raise the question of whether we had done more intravascular imaging, would it really have had a dramatic impact? I'm not sure. We'll never really know, but I just raised that point there to highlight or to defend. And the other thing to say is that, at least in the United States, 12% rate is about average for how much intravascular imaging is used. So thank you.
It seems that the rate of intravascular imaging and the rate of multiple arterial grafts are both lower than we would like them to be.
Exactly.
Yeah, no, I think you're right.
I have a comment. I have a comment too, and I actually have two different comments to make. The first one is, as a young surgeon interested in coronaries, your attention to the precise and meticulous attention that you mentioned, to me, it's a very important comment. And I believe also that creating a culture around coronary surgery and try to create a community of surgeons dedicated to coronary surgery is one of the important advantages that can improve outcomes in our specialties. The second comment is more of a question. I've seen throughout the literature a tendency that is almost split in two directed objects. In the last 5 years, the literature in coronary revascularization has moved on one side saying less is more. Do not stent every lesion. Control your oculostenotic reflex and try to instead optimize the medical therapy. You can wait from, even if you know that you have coronary artery disease, it's safe to wait. So there is almost a tendency in literature towards less is better. But then there is a huge counter side that is complete revascularization, both in surgery and in PCIs, is the standard of care. If I, as a young surgeon involving coronary, do not perform 4 bypass in my sternotomy cases, my referring cardiologist start to call my senior partner and send him cases because I didn't perform that 1 millimeter OM3, bypass. So is where we stand as a whole. Are we looking at different type of patients? Is that the reasons? Is the fact that in moderate syntax or in patient with a less burden of coronary artery disease, it is probably safe to do less? And if so, and this is the second part, in these intermediate syntax patients that have been included in FAME-3 trial, don't you think that the real advantage of bypass surgery with respect of PCI was limited to Lima 2 LAD? And if a surgeon can perform, and I hope you will, Dr. Fearon, be the primary investigator of a FAME-4 trial, where we do robotic Lima 2 LAD plus FFR PCI for the non-LAD lesions versus CABG, and we show that quality of life is improved and outcomes are better than FFR multivessel PCI or so. So can we imagine what is the future?
Yeah, that's great comments. And you took the words out of my mouth about the FAME-4 trial, quote unquote, but about a future trial, because I think that would be an interesting thing to look at. As far as, I'll just go back to the complete revascularization. And I agree. I mean, in the interventional community, there are these two kind of divergent or discordant approaches that you just highlighted between, just spot stenting, so to speak, and then, full complete opening up all the CTOs, revascularization. And I think we need more data. In FAME-3, I think we have some analyses going on, which will be interesting, where we're going to look at, what we term functional complete revascularization, where we look at all the lesions that were FFR positive and got treated, and the ones that are FFR negative, and what happens to those deferred lesions previous studies have shown that they do quite well, but we'll see how it applies in a more complex multivessel disease group. And the functional syntax score, where we calculate the syntax score and then subtract out any vessels that had a negative FFR, I think will also be interesting to look at, and whether we've seen in other data sets that the functional syntax score is actually more predictive of events than the syntax score. So I'm kind of a believer of functional complete revascularization is what's necessary, and not total anatomic complete, because medical therapy has become so effective. So, and then your second point, I think, is a great one regarding the main benefit being from Lima to LAD. And we participated in the hybrid trial that Dr. Puskas and others had led. And unfortunately, that was so challenging. And I think, maybe one reason was because, patients got the option of having total PCI. And as we all know, patients will choose a less invasive approach if given that alternative. And so I think the way you described it, of comparing, Lima hybrid surgery versus full bypass, would be a nice way of looking at it also. And with FFR guided PCI of the non-culprits, and it'd be really interesting to see how those two strategies compare.
Dr. Paskas, Dr. Taggart.
Well, Bill, I agree with everything you've said. It seems to be commonly the case. We were really challenged to complete the hybrid trial for a lot of different reasons, and most of them are outside the scope of our conversation today. That said, I'm going to push back a little against the statement that my colleague, Dr. Torregrosa, made, despite the fact that I'm immensely proud of having played a role in mentoring him and having taught him robotic coronary bypass. I do not think that the only thing coronary surgery does is provide perfusion to the anterior wall and septum via a Lima to the LAD. I will say that's the most important thing that we do, but it's not the only thing. For some patients, the relative proportion of that benefit is immense, that it really is the lion's share of the value of a coronary bypass is perfusion to the LAD territory. For the reasons we all know, it's the biggest territory. It provides the anterior wall of the left ventricle, which provides most of the forward propulsion to the left ventricular outflow. It provides flow to the septum, which contributes importantly to right ventricular function as well. So it really is, it's the queen on the chessboard, if you will. But you can win a game without your queen. And you can lose a game if you don't play the queen right. So there is more than just that to coronary bypass. And that's a case-by-case evaluation. We've all seen patients who had, no disease in the LAD, and they're crippled by angina or even heart failure, or both, due to lesions or failed stents or failed grafts in the right and circumflex coronary arteries. So the LAD is not the whole game, but it's a big part of the game. That said, I think that is another argument for multiple arterial grafts. I mean, we've all come to accept that a Lima to the LAD is the standard of care in coronary surgery. And we should remember historically that was intensely challenged. The original proponents of Lima to LAD included George Green, a surgeon here in New York who did the first internal mammary graft to the LAD at the hospital where I now work. He had the job that I have now when I was 8 years old. He's now in his 90s. And when he first did the Lima to the LAD, people thought he was nuts. Surgeons contested this vigorously. Too hard to do. The mammary artery is too fragile. We can never sew it precisely enough. It's too small. It doesn't carry enough flow. People will die. There were all sorts of criticisms of this novel approach. And now it's standard. And I would argue that we're seeing the same pushback against multiple arterial grafts that we saw against single arterial grafts a generation and a half ago. Now, the prize is probably smaller. The incremental benefit of each additional internal mammary or arterial graft must, by definition, be smaller than the benefit of the first and then the second. But that said, I think it's illogical to believe there's no benefit.
Yeah.
I think we should acknowledge that there will be decreasing benefit with each additional arterial graft, but the benefit will always be positive.
Yeah.
And there's the motivation to incrementally improve what we do, just as our interventional colleagues have done so brilliantly, improving not just the stents, courtesy of billions of dollars of industrial investment, but also the approaches, the radial artery approach. Both my parents had radial artery catheterizations. One had a life-saving stent in the right coronary. You know, that they walk out of the hospital that day because of the approach techniques and the delivery techniques for these novel stents. And we surgeons need to continue to iterate as well, incrementally improving every single aspect of what we offer our patients.
Yeah. So if I can just add to that, John, I mean, I agree with everything Bill said and that you've said, but I think the difference between PCI and CABG is not only the CABG protecting the mid-coronary circulation and therefore making new proximal lesions irrelevant, but as Tom Lusher showed us in the New England Journal of Medicine 3 decades ago, the internal mammary artery elutes nitric oxide into the coronary circulation that protects that distal vessel. And the radial artery produces nitric oxide as well, not as much as the IMA, but more than a vein graft. So over the longer term, it's not just bypassing the proximal lesions, but it's producing that benefit of internal mammary artery. But I would like to congratulate Dr. Fearon and the FAME3 investigators for a super study reported very fairly, and which I think will in due course become arguably the most influential study ever of PCI versus CABG.
Thank you so much for this comment. We have also a question from the audience. There is a question about what proportion of patients that were reviewed ended up being suitable for recruitment in FAME3.
Great, thanks. Well, first I'd like to thank Dr. Taggart for those comments. Those are very meaningful, and I appreciate that. You know, as I had mentioned regarding the question about the proportion of patients who ended up being suitable, because FAME3, compared to some of these industry-sponsored and run studies, FAME3 was done more on a shoestring budget. We didn't have the capability of having coordinators logging every single patient that came through each site's heart team or hospital and, you know, documenting what approach they got. So we just focused on patients who consented for the procedure. And then whether they were accepted. So we don't have an exact number. My sense is that this was a select population like any trial. There were likely patients who had clearly very complex disease that the heart team did not feel was amenable for PCI, and then they went straight to CABG. The other thing I would say is that it probably did also go the other way. I mentioned in the presentation that 10% of patients had quote unquote FFR guided CABG. You know, presumably, since they were enrolled, all 3 vessels were FFR positive. So likely that means there were at least another 10% or maybe more, who knows, that had FFR done ahead of time and then didn't have 3 vessel disease and therefore were not included, sort of skewing away, you know, lower risk patients. Although we've talked about the syntax score, I think there's an argument to be made that this was, you know, a higher risk group than we had anticipated or had our goal for enrolling. You know, we had seen the Excel trial and other studies that had shown that lower complex patients do better with PCI. So, you know, our goal was to try to look at that group more than the high complexity group. And I think, you know, it can be looked at both ways as far as the population, but you know, of course, this was a select group. And the other thing we haven't discussed was it was mostly men. You know, we need to look at outcomes in women more. It wasn't, you know, there wasn't a great underrepresented population of, you know, a diverse population. It was all mostly Caucasians. And so I think you have to take all of that into account when you're using these data to advise your patients.
So, Bill, let me ask you a question following on that. There is now, among the many initiatives within cardiovascular medicine, a push towards less invasive diagnostic angiography, specifically CAT scan angio, CT angio, and CT-FFR. In fact, as you, I'm sure, are aware, there's a small sort of pilot level study called Fast Track Cabbage that Patrick Sorois and others have organized, which we intend to participate at Mount Sinai. And we will then be obliged to perform coronary bypass surgery based on CT angio and CT-FFR. So two questions. What do you think of FFR-guided CABG? I'd like to hear from the whole panel. FFR-guided CABG by presence invasive FFR. Should we do or should we not do? And if we should do it with invasive FFR, then why not do it with non-invasive FFR? And how does that change the landscape of cardiovascular medicine?
Great, great questions. My interpretation of the few randomized studies that have compared FFR-guided CABG to angio-guided CABG is that they haven't really shown a significant difference in clinical outcomes. They've shown that it can allow for a less complex procedure, meaning fewer grafts needed and maybe shorter time on the pump, but that hasn't, at least in these smaller studies, translated into a really dramatic difference in clinical outcomes. So that was part of the reason why we didn't include or mandate FFR guidance in the CABG arm. The other reason is that a lot of sites, receive patients with just the angiogram alone. That's sort of the current practice. People do the angiogram and then they refer for bypass. And we wanted to mimic practice. And if we were going to mandate FFR guidance, these patients would have had to go back to the cath lab, had FFR measured, and then get potentially randomized to CABG and have had an unnecessary invasive procedure. So logistically, it didn't make a lot of sense to do that. And so I think we need more data. Again, we need a bigger study to see whether really FFR guided CABG does have a benefit. But at least based on the current data, I haven't been that impressed. And as far as FFR CT, first of all, I should mention HeartFlow, the company or the main company doing FFR CT, was developed at Stanford by colleagues of mine, and I have been involved with that company. As far as its role, my feeling is it's a better non-invasive test than a lot of our other stress imaging studies, and certainly better than CTA alone. It clearly improves the specificity by eliminating a lot of these false positives that we see with CTA alone. So I think it's a quite useful technique in that regard. We'll see what this study shows, whether you can just go ahead and skip the angiogram and getting more invasive data or not. But so I kind of view it as a better gatekeeper to the cath lab than traditional techniques.
John, if I can just make a quick comment. I think the reason FFR-guided CABG has not been particularly useful is we know from the findings of the early FAME studies that if you look at an angiographic stenosis, if it's above 90%, the eye's pretty good at telling you you've got a significant stenosis. If it's anywhere below 80, you might as well toss a coin as to how functionally significant that stenosis is. So what I think the real role of FFR in CABG might be is identifying those intermediate lesions where you're not sure of the severity of the functional stenosis, but at the same time allows you to guide where to place your arterial grafts. Because we know the one thing that's not good for arterial grafts is a lot of competitive flow. So I think the real advantage of FFR in CABG might be identifying those intermediate stenosis where functionally they really are important, and therefore where an arterial graft would have a very good chance of long-term success. And if it's less than or an insignificant stenosis, probably putting a vein graft on it does no harm, because if the vein graft goes down, it doesn't make any difference, but it's not as susceptible to competitive flow as an arterial graft.
So I would add a nuance to that. David, and say that, I tend to use FFR to help guide the selection of the kind of arterial graft.
Yes.
Is it a sequential graft? Is it one inflow to three outflows? is it a composite or complex configuration of arteriographs? If the FFR is borderline or the angiographic appearance is borderline, but that's an important vessel that needs bypassing because we know progression of that stenosis will lead to a major ischemia, then I'll dedicate an arteriograph to that distal vessel rather than having it share inflow or outflow with other coronary arteries. So I will sort of go to another level of thinking about how to deploy the arteriograph in that scenario.
Excellent comment. We are above an hour. That was the time that we originally allocated for this event. We can, I'm sure, keep staying online and talk about it because that was a phenomenal trial, and I want to really again thanks Dr. Fearon for your phenomenal presentation, the way in which you exposed the data and you presented them, and for your presence here. So many questions are still remain in my mind. I would have loved also to ask Dr. Kasselman the use of TTFM in the surgical arm of FAME3. You know, Dr. Fearon, we measure the flow during the bypass, but unfortunately, again, as another quality marker of bypass, not many surgeons, particularly, and I talk about United States, uses TTFM routinely in their bypass surgery. So it would have been interesting to see what was the adoption in the surgical arm of FAME3 trial, and if that has had a potential interesting data with the stenosis of the vessel itself. But again, I think that for the amount of time we have allocated to this one, that was an excellent conversation. I want to thank you so much, Dr. Fearon, for being here with us today, this morning, and joining from 8 o'clock in the morning in San Francisco on holiday weekend. I want to thank you, Dr. Kasselman, even if he's not here in this moment, and we saw him coming back and forth on a train in France. That's a lot of commitment to be part of it, and thanks again to him. And Dr. John Pascas, Dr. David Taggart, thank you for ISCAS and the creation of these events for maintaining the education among coronary surgeons and interventional cardiologists, creating this community that wants more and more to work together, not one against the other one, but is PCI and CABG as treatment together to address coronary artery disease in different patients, being understanding which one do perform better in which patients, how can we tailor our treatments around each individual patient. I think the collaboration. Please.
If I can also add my thanks to Dr. Fearon for his super presentation, and again to the FAME3 investigators for what they've done. Thanks to John for the great moderation, but especially thanks to you for organizing this absolutely outstanding session. It's been fantastic. Well done.
Thank you so much. Really, thank you. This is it's fun. We learn all together. It's very nice, and I think this is exactly the sense. So I want to thank everyone also who sent us messages, feedback from all of the social media platforms. Have been a lot of them. Thank you for watching. Thank you for learning on a Saturday morning with us, and looking for our next appointment or for meeting in person to our next meeting. Thank you so much, everyone.
Thank you very much.
Thank you.
And I will end the broadcast live, or we can stay on.
Happy Memorial Day.